Please start, sir. We are live.
A very good morning. This is wonderful Sunday morning, and I would like to welcome all the distinguished delegates and our eminent speaker for today, Dr. Kathik Sabapati sir from Chennai. And I would like, my name is Satish Rama Joshikar from Zydus Life Sciences. Would like to welcome you on this scientific digital platform called CLEARTalk. On behalf of Zydus Life Sciences, I would like to express my most sincere gratitude for your presence in this scientific webinar. Giving a small brief about ClearTalk. ClearTalk is one more initiative and facet to unite against dyslipidemia. As you are all aware that 1.24 crore of Indian population is uncontrolled LDL cholesterol population, and 7 out of 10 Indians are uncontrolled LDL cholesterol. So the recent development in the field of dyslipidemia is bempedoic acid. I would like to call upon our today's speaker for to deliver best and recent development in the field of dyslipidemia from American College of Cardiology, recently conducted in the month of March, that clear outcomes trial. And this is a CVOT trial. This is late breaking clear outcome trial, which was presented in ACC 2023. This program is basically to give awareness about bempedoic acid as an add-on choice to statins, and increasing the usage of bempedoic acid amongst all the physicians and general practitioners. It's basically to upgrade our late breaking knowledge on CVOT and clear all our doubts on clear outcome trials. Without wasting much of a time, I would like to give a brief introductory speech and presentation about Dr. Kathik Sabapati sir. Dr. Kathik Sabapati sir is a consultant interventional cardiologist at Medway Heart Institute and CVM Hospital, Chennai. Sir is also life member of IMA, CSI, and API. Sir has practicing physician and cardiologist for the past 12 years, and he has many publications to his credit in national as well as international journals. Sir has also recently judged the paper presentation which was on custom made sandwich stenting for treatment of artery perfusion, and would like to give more brief. This is the just brief introduction of sirs. Would like to call sir on the stage to deliver the best clear outcomes trial which was presented in ACC 2023. So would like to hand over session without wasting much of time to Dr. Kathik Sabapati sir. Thank you.
Good morning all, and thank you for the introduction. So we'll be proceeding with the good morning all. So today I'll be talking about the clear outcome trials. So I'm Dr. Kathik Sabapati, practicing in Chennai. So this is today's topic: bempedoic acid through the lenses of clear outcome trial. So as you all know, like each 1 millimole reduction of LDL gives more CV events reduction according to the number of years in trial. So this is a meta-analysis data. So the number of years the patient is in the trial, and for each millimole you can see the relative risk reduction. So as you all know, LDL is the main predictor of increased LDL is the main predictor of adverse cardiac events, and it causes progression of ASCVD. So management of dyslipidemia is on high priority because it decreases the ASCVD and its adverse events. So as you all know, statins are the first line therapy. Till now, it is one of the best drugs, but there are few concerns. Do all statin users achieve LDL goals as per guideline recommendations? So how to achieve LDL target after maximally tolerated dose of statins. So regarding this, the LDL goals have drastically gone down since 2019 ESC recommendations, and it is very difficult to achieve that kind of LDL with statins alone. Okay, and especially we Indians are not very tolerant about the high dose of statins. Most patients do not tolerate high intensity statins like say atorvastatin of 80 mg or rosuvastatin of 40 mg for a longer time. We start them, but many of them come with the side effects like myalgia, myositis, and severe body pain, and we have to reduce the dose. But when we are reducing the dose, the LDL target is being missed. So how do we address both these concerns? So this is what I was talking about. So the as far as LDL is concerned, there is no safe limit. The lower is better for longer. So if the LDL levels are below 55, so that is the most desirable, and it should be maintained below that level for a longer period of time. So as you all know, these are the various drugs, and among all the drugs, the PCSK9 has a very high reduction of LDLs, and followed by statins and bile acid sequestrants. This is a surgical procedure. So LDL-C target of ESC in 2016 versus 2019. As I told you, the targets have been drastically reduced. So the low risk is same, less than for low. So I'll be elaborating about what are the low risk, moderate risk, and high risk. So the low risk patients, the targets are same. And for moderate risk, it has come to 100 from 115. And for high risk, it is below 70. So it is below 70 for high risk patients. And the drastic change comes here in the very high risk. The LDL target for as per ESC recommendation is only 55. So I was telling you what is this high risk, low risk, moderate risk. So very high risk patients are with patients with documented CVD, MI, stroke, or aortic aneurysm, or peripheral vascular disease, or long-standing diabetes with a target organ damage, severe CKD, or a calculated score. Score is a online calculator for ASCVD risk. It's available online, and that is used by the European nations. So if the risk more than 10%, it is very high risk. So high risk patients are markedly elevated factors like cholesterol, diabetes, moderate CKD, and a calculated score of 5 to 10%. That is a high risk. Moderate risk comes the score between 1 to 5%, and low risk is less than 1%. So based on the revised 2019 guidelines, how many patients do have controlled LDL cholesterol below the target levels? So this was done using the Da Vinci study. So 18 countries in the Europe were involved, and around 6,000 patients were enrolled. So the main aim was to evaluate the percentage of people who were on LDL targets based upon the 2019 guidelines. So from the study, it is noted that around 27% of patients were receiving high intensity statin. So among these 27%, only 30% achieved lipid goals with high intensity statin. So this comes here. So this is the 53 is based upon the 2016 ESC targets. But when we reduce the target, we have only 30% who have achieved the target of ESI 2019, that is less than 55. So in very high risk patients, almost 37% were on high intensity statins, and only 22% were able to achieve the ESC 2019 targets. So it means only 1 in 4 approximately are achieving the targets. So what was this I was saying about high intensity, low intensity? What is this? The intensity of the regimen is defined as the percentage reduction of LDL. So if it is more than 50% reduction, it is called a high intensity, and 30 to 50% is moderate intensity. So among the patients who cannot tolerate the recommended intensity because of the side effects, a non-statin lipid modifying agent is recommended. So I was telling you, the moderate intensity statin, the average reduction is around 30. So high intensity is 50, and high density plus ezetimibe, it's around 65. So as I told you earlier, the best reduction of LDL comes with the PCSK9, but again, it comes with the cost, side effects, and it's an injection. So that is here. So among these statins, what we have, atorvastatin and rosuvastatin, these are the commonly used. These both are only moderate and high intensity. At any dose, it is only moderate. So so what happens if the patient doesn't achieve LDL targets and with the maximum dose, tolerated dose? So how do we proceed? So this is a recommendation, a flowchart from the AAC 2019. So once you have started the drug and the goal is being determined based upon the patient's risk, and we give the statin as the highest possible or tolerated dose. The goal is not reached, we have to add ezetimibe. If it is still not reached, we have to add PCSK9. So what is this ezetimibe? Ezetimibe is, it reduces only around 10 to 15%, as you have seen in the previous slide. So from 50, it comes only to 60, 65. So the efficacy is around 10 to 65. And still, even after ezetimibe, many patients have not achieved LDL targets. So, and many patients are not willing for PCSK9 because of the cost, especially the cost, and being an injection. And it's a very new drug. As you all know, previously, 10 years back when SGLT2 inhibitors, most physicians, diabetologists were reluctant to use, stating about UTI. Similarly, there's a very high, but now left and right, they're using all SGLT2 inhibitors. Similarly, right now, there's a very big stigmata about PCSK9 because it's an inhibitor and cost. It comes around 20 to 25,000. So there's a big gap between ezetimibe and PCSK9. So do we have any drug? Yes. Now we have this bempedoic acid. So it's an oral drug. It has a half-life of 21 hours, and 70% is through the kidneys, and 5% is through the feces, and less than 2% is unchanged drug during kidney. So there is no dosage adjustment necessary in case of renal impairment, even for hepatic impairment. So there's one concern. There is a rise in serum uric acid levels during the use. So patients with a history of gout, there should be a high vigilance, and patients who are on corticosteroids or fluoroquinolones, there's a warning for tendon rupture. So if the patient has history of tendon rupture, you should be cautious. And patients above 60 years with renal failure, if there is a new onset of tendon rupture, we have to stop using bempedoic acid. And it is not generally recommended during pregnancy and lactation. So this is the late trial which was released in the recent ACC. The clear outcome, cholesterol lowering via bempedoic acid and ACL. I didn't tell you about the mechanism. Bempedoic acid is an ATP citrate lyase. So this enzyme comes well before the statin HMG-CoA reductase, and it inhibits an early step. Whereas the ezetimibe is an cholesterol uptake inhibitor. Okay. So this is the study model of clear outcome. After screening, the patients were blinded, and they were put into two groups, bempedoic acid in one group and placebo in other group, along with statin and other recommended therapy. So the regular treatment was going on, and they were randomized to either of the groups with bempedoic acid or placebo. And the study had compared various factors, which we'll be seeing later. So almost all the factors were matched with the groups, and it was similar, like almost everything, including statin use, ezetimibe use, diabetes, previous history of coronary artery disease, everything were matched between the two, placebo and group, bempedoic acid group. So as you all see, the 4-point MACE has come down by 13% relative risk reduction, and 3-point MACE is 15%. And MI was reduced by 23%. It's a very significant reduction. And coronary revascularization was also reduced by 19%. As you can see, all are statistically significant when compared with the standard treatment. So this is the background. Around 15% of treated patients, they have only like statin intolerance is very common, and this prevents the patients from achieving LDL targets. So as I told you, it's an ATP citrate lyase which inhibits the early part of cholesterol formation. And now the CV outcomes have been assessed with this CLEARTalk trial. So this is the 4-point MACE and 3-point MACE. It is so all the primary and secondary endpoints were statistically significant, and it's a great relative risk reduction with bempedoic acid when compared to the standard cholesterol therapy, that is statin and ezetimibe. So this is it. The 4-point MACE was reduced by 13, 3-point was 15%, and MI, both non-fatal and fatal, was 23%, and revascularization by 19%. And it is also seen that there was around 21.7% reduction in LDL-C. As I told you, the ezetimibe is only 10 to 15%. And the injectable was more than 60%, but there was a big gap. So around, say, the 50% is being reduced by the statins. So it comes around 20 to 25%. So this is a very good drug when compared to ezetimibe, and it can be even added with ezetimibe. And with only oral drugs, because people, they don't have any difficulty in starting oral drugs, and even physicians. So there's a big gap between ezetimibe and say PCSK9, which is now filled by bempedoic acid. It has also reduced the highly sensitive CRP by 22%. So what are the side effects? As I told you, like there's an increased incidence of gout, or there is increase in the uric acid levels and tendon rupture. These are the few side effects. And the other common side effects, there is no big difference. There was a marginal increase in worsening of creatinine and progression of CKD with the use of bempedoic acid. So the conclusion is the bempedoic acid becomes the first ATP citrate lyase inhibitor and first oral non-statin to demonstrate statistically significant 4-point MACE reduction, and who are not able to tolerate statins and still with an elevated LDL targets. So this is the previous flowchart which I told you. So there's a big gap here after ezetimibe and PCSK9. So you can add probably in the next trial or recommendation, next recommendation, you'll be seeing bempedoic acid either before ezetimibe or along with ezetimibe, and before PCSK9. So it's an effective alternative for statin intolerant patients, as demonstrated by the CLEAR outcome trial. It is well tolerated, and there are no major side effects. And LDL levels and HSCRP are reduced significantly. All the primary and secondary endpoints were statistically significant, and there is a great relative risk reduction in the bempedoic acid group. And it is an effective approach to reduce major cardiovascular events in statin intolerant patients. And thank you. Are there any questions?
Yes, sir. There are few questions. There are few questions which I received from the audience, which I'll ask one by one. Sir, you were talking about now. Just you spoken about with bempedoic acid being coming in guidelines before PCSK9 or ezetimibe. Recently, International Lipid Expert Panel has also recommended usage of bempedoic acid before PCSK9. So that is one recent development which we would like to share here on this platform. Sir, first question, you initially spoken about stricter guidelines becoming stricter and LDL cholesterol becoming lower and lower as per the 2019 guidelines of ESC. So what you target, sir, in your practice, day-to-day practice? How much LDL cholesterol you target in different
So
patient categories?
yeah. Mostly I see two varieties of patients. One is the patients who have diabetes, hypertension, but still they don't have an established CVD. For those patients, I usually target less than 100. And for patients with the other 50% of the patients are patients who had a myocardial infarction, who had stroke, who have had an ASCVD, or already had an event. So these are the very high risk patients. So I usually target below 70, and there is a subset of patients where they continue to have second events, say a reinfarct, a recurrent stroke, a recurrent myocardial infarction. So in these type of patients, I strictly go below 55. But still, as you can see, why? Because the recommendations have still shown, even if there is a one event, you should go below 55. Because most patients, they were not tolerating high dose statins. We usually, after an MI, we start them on 80 mg, but they come back after 2 or 3 months saying severe myalgia. They say that the chest pain is better, and this myalgia is still worse than the chest pain. So we are forced to decrease the dose. And ezetimibe we have added, but that was not that. There was no, like, say, what this was 100, it comes around 80. That's it. So it doesn't still go below 70. But now with the use of bempedoic acid, we can decrease the dose of statin to the maximum tolerated, and then we can add bempedoic acid. So hopefully, I think even after patients with a single event, I'll be targeting below 55 with the use of bempedoic acid.
Thank you so much, sir. And you have already answered the question that should I increase the dose of statin or to add bempedoic acid or the ezetimibe. So you already explained in this very nicely. Sir, this next question which is being raised is, if we go LDL cholesterol below 40 milligram as per the recommendation, can it lead to any complication, neurological complication?
Yeah, there's one trial called Sparkle trial, which states that very high intensity statin for a longer duration may cause an increased incidence of intracerebral hemorrhage. But still, there are many meta-analysis, and this has not been proved. But still, there's a concern. So if you use, high intensity statins for a longer period of time, there is an increased risk of ICH. But still, that also could be considered as an ASCVD, because if you don't reduce the risk, the patient is going to get an ischemic stroke or an MI and going to die. So there is a concern, but still it has not been proved. Other than that, there is no side, apart from the side effects of drugs, there is no increased incidence of any other disease of decreasing LDL levels.
So the advantage of bempedoic acid is there's no myalgia or muscle pain. So would you like to replace, one question is, would you like to replace statin with bempedoic acid?
Yeah, as of now, the first and the best proven drug is statins. So either along with statins, or there is a very rare subset of patients who are they're not tolerating even low intensity statins. In that case, we can try this. But as of now, and as of my experience and worldwide recommendations, statin is the first drug. And if after maximal tolerated dose, the next is bempedoic acid or ezetimibe.
So you have spoken about Da Vinci study, which says that 66% of the patients are still uncontrolled on LDL cholesterol. So the question is, like, how in your day-to-day practice you consider consider the option of bempedoic acid when statin induced statin associated muscle symptoms are there, and also there's uncontrolled LDL cholesterol, how frequently you see with
Yeah,
statin.
it is not as frequent as what the Da Vinci trial, and that's Western data. Probably in the Indian subcontinent, uh, around 60 to 70% we achieve, around 50 to 70% we achieve targets with these statins.
Sir, Lipid Association of India has spoken about increase. There is still residual risk which is there with the patient, residual CV risk. So, would you like to throw on some light on this?
I don't get the question. You were asking about the residual lipid risk.
Even after high intensity statin, there is a residual CV risk which is associated and which is being spoken about. Lipid Association of India's one of the clinical trial. So, what is your take on this?
Yeah, it is not only the statins. So it doesn't mean that if you uh, uh, treat dyslipidemia alone, there is an you decrease ASCVD. There are various factors, and if patients are not able to get the targets with statins, and even if they are getting recurrent CV events, even after the maximal dose of statins and controlled HDL LDL levels, you can try other drugs like bempedoic and estimate, and even PCSK9.
Sir, there's one question. How bempedoic acid is safe for longer duration, and is it benefited more in diabetes mellitus patients?
So the safety, it is a new drug. It's been in the market for 1 to 2 years. So for long-term duration, so far so good. So, but still more data has to be data is as needed. And the second question was about.
Second question is about diabetes. In diabetes patient, how bempedoic acid is beneficial?
It's as good as statin. That's it. No specific. I don't see any benefit over in specifically diabetic patients. Maybe I'm not aware of it.
Okay, sir. There's another question which is being asked is if patient is having elevated LDL cholesterol with moderate statin dose, then what should we do? Means should we increase the dose of statin or add bempedoic acid?
If he's tolerating statins, you can increase. If he's not tolerating statins, you can add bempedoic acid.
Thank you so much, sir. These were the questions. There's another question which has been raised is bempedoic acid in mild to moderate CKD patient. Is it recommended or safe?
Yeah, you can use. There's no dose modification required, but you need to monitor the creatines and progression of CKD.
Thank you so much, sir. This was such a lucid and elaborative presentation to the point. Would like to have your final closing remarks before we conclude this clear talk.
Yeah, so as I told you, like there's a big gap between maximum dose of tolerated statins and PCSK9. So right now it is being filled only by estimate, which is very mild intensity, and it reduces LDL by only 10 to 15%. So this gap was is now filled by bempedoic acid. So after the maximum tolerated dose of statin, and if the patient has not achieved the LDL targets, you can add bempedoic acid. This is an oral drug and comparatively cheaper when compared to PCSK9. So hopefully bempedoic acid will bridge the gap between the PCSK9 and maximum tolerated statin dose. Thank you.
Sir, it was indeed a pleasure having and honor having you on this event called CLEARTalk and clearing all our doubts about bempedoic acid. On behalf of Zydus Life Sciences, we would like to extend our most sincere thanks for your comprehensive session, sir. And we are sure that our delegates have definitely got enlightened regarding the usage of bempedoic acid. as you have covered all the aspects of Bemdac acid in this session of CLEARTalk. At the same time, we would like to thank all our delegates for sparing this Sunday, and would like to request everybody to thank you all, and would like to appreciate your presence on this Sunday morning with us on the scientific platform called CLEARTalk. Thank you once again, all of you, and have a great day, great Sunday. Enjoy your day with your family. And thank you, sir,
Thank
for
you.
being with us and delivering this such a wonderful CLEARTalk. Thank you, sir.
Thank you. Thank you.